This is Dr. Harold Pierre. Thank you for choosing me as your doctor. For all other viewers, please consult your physicians to determine how this information applies to you. In the United States, overdose is now a leading cause of accidental death, with most deaths due to the prescription opioids. This should come as no surprise since prescription opioids are the second most commonly abused of all drug classes, affecting an estimated 4.8 million Americans. What may be a surprise is the fact that for years, the number one prescribed medication had been hydrocodone. Its sales far outpace any other medication for hypertension, high cholesterol, and even diabetes. With so many Americans afflicted with opioid dependence, the question isn't whether treatment is indicated, it's often which treatment modality to pursue. Treatment options may include detox, or it may be ongoing maintenance with an opioid replacement medication such as Suboxone. Now for the rest of the video, I will refer to Suboxone as its active ingredient, buprenorphine. For heroin dependence, the literature is quite clear. Heroin-dependent patients demonstrated improved outcomes with methadone maintenance compared with methadone taper. The patients maintained on methadone demonstrated lower HIV transmission, less criminal behavior, and decreased mortality. Now, surely, patients with prescription opioid dependence differ significantly from patients who have heroin dependence. Opioid-dependent patients have shorter histories of opioid dependence, lower levels of physical dependence, better occupational and social functioning, and improved treatment outcomes. These important characteristics may lead to different treatment outcomes. Now, most often in practice, patients request and receive a taper. However, is this in fact the best choice for patients? Are they better off with another treatment plan? But the only way we would know is to compare a taper group versus a maintenance group and determine which has the better outcome. That was exactly the goal of Dr. Phelan and colleagues in this 2014 paper. They set out to determine the efficacy of buprenorphine taper versus ongoing maintenance therapy with buprenorphine in a primary care-based setting. This was an 18-week study conducted at the primary care center of the Yale New Haven Hospital. 113 volunteers who met the DSM-4 criteria for opioid dependence. They were randomly assigned to two different wings. One wing would receive the buprenorphine taper, the other would be maintained on buprenorphine. Now, this was an open-label study, which meant that the doctors as well as the patients knew what medications they were receiving. Weekly urine drug screens were performed for illicit opioid use. The patients reported days per week of illicit opioid use, and the patients also reported the maximum consecutive days of abstinence from illegal opioid use. We first encounter a difference in that the taper group provided less urine samples. They also provided fewer patient-reported assessments. For the maintenance group, 81.7% of their self-reported abstinence were confirmed by negative urine versus 74.6% for the taper group. The maintenance group came out ahead in several categories: samples of urine provided, average days retained in the trial, average maximum consecutive weeks of opioid abstinence. And after the taper was completed and the subjects in the taper group were off of buprenorphine, the maintenance group still won out by providing double the negative urines. 28% of the tapered group relapsed and required reinitiation onto buprenorphine therapy. So the recommendation from the authors is that a buprenorphine taper should be used sparingly, if at all, in the primary care treatment of patients dependent on prescription opioids. Their research demonstrated that the taper group did poorly on multiple categories. And for physicians who are managing patients with opioid dependence, the risk of relapse, including overdose and death, have to be taken into account when considering a taper. There is one thing that I absolutely must convey to you, and it's the fact that recovery from opioid dependence is a marathon and not a sprint. My most successful patients are investing equal time to treatment as the duration of their addiction. So for someone who's spent 10 years battling heroin addiction, they should plan on 10 years of treatment and then a lifelong commitment to avoiding triggers for relapse. Science has yet to answer the reasons why opioid dependence causes such a long impairment. But what I know for sure, it's not your character. Genetics and so many other factors play the greatest roles. It's predictable that most people who enter opioid detox will fail and relapse within a year, having nothing to do with their efforts. It takes me a year or more to successfully taper a patient off of opioids or Suboxone, and I only taper individuals who have achieved a high level of functioning. The worst thing I could do as your doctor would be to taper you to failure because your family insisted, you insisted, before eliminating the triggers that will cause you to relapse. So stay tuned to my YouTube channel. I have at least 100 videos in the works, and I'm constantly planning new ones as the science of addiction changes daily.